My name is Rodrigo. I'm a second year resident here at the service, and I'm going to present the ground of emergency room. And the advisor is Dr. Letícia Santana, and radio sector is Luciana Noia. And a special thanks to Dr. Gustavo Samico for helping with this case. Our patient is a 47-year-old male patient that was referred to the emergency department for evaluation to a progressive decreased visual acuity in the left eye since November of last year, with a worsening in December and subsequent involvement of the contralateral eye. He also reports periorbital bend associated with eye movements and deny any previous similar episodes. For past semester history, he says he had gastritis and nephrolithiasis. He denies smoking or alcohol use and has no comorbidities. He denies any tertiary traumas or diseases. For family histories is unremarkable and are currently using prednisone 6 mg daily on a tapering exedu, deslasambrazoles and for 6 mg daily and on dancetrona as needed. He denies using any eye drops. So here for the ophthalmologic examination, and the visual acute with pinhole is 106 for the right eye and counter features for the left eye. He had a relative afferent pupillary defect on the left eye. The extraocular motility was preserved in both eyes, and the anterior biomicroscopy was remarkable in both eyes, with a clear conjunctiva, transparent cornea, former anterior chamber with no reaction, and he was phasic. Intraocular pressure was 19 millimeters of mercury in the right eye and 15 in the left eye. And for fundoscopy, I will show some photos. Here is the right eye fundus. We can see it's remarkable with a pink op disc, sharp margins, cup to disc ratio of about 0.4, macula and vessels normal, and the retina is attached. And here is the left eye fundus. Here we have some alterations. With elevated op disc with blurred margins. We have turtles and incortical vessels in all quadrants. We have also hemorrhages also in all quadrants, but have more peripapillary. And we have some yellowish lesions temporal to the macula. And the retina is attached. So for our diagnosis hypothesis for this case, we have to think about a male who is about 47 years with progressive visual loss of both eyes, with some alterations in the fundus and also a pupillary defect on the left eye. We can think about inflammatory or demyelinating diseases, just like atypical optic neuritis, inflammatory papillitis, and ETG4 related diseases, local compressive and tumoral lesions, especially about his left eye, with optic nerve tumor or optic nerve sheath meningioma. We can think about infiltrative or neoplastic diseases like leptomeningeal carcinomatosis, a central nervous system lymphoma, dural metastasis, and neoplastic infiltrations of the optic nerve. There are also granulomatous diseases like sarcoidosis, granulomatous tuberculosis. and infections, diseases like syphilis, tuberculosis, neurocryptococcosis, and toxoplasmosis. So going on, for the management of these patients, we want an investigation with an MRI contrast of the brain and orbital, a neurologic consultation with a lumbar puncture. And we will expand our laboratory testing with infection serologies, inflammatory markers, and autoimmune panel, and also an IgG4. For the initial therapeutic management, we will maintain the corticosteroid therapy and do a hospital admission for a better investigation of the causes. So at January 16, we had our first brain MRI, and the key findings are signs of left optic perineuritis with a westraxial lesion with a dural base. We also had some lesions with dural implementation in the posterior fossa and multiple diffuse nodular leptomeningeal thickenings. The radiologic team was finding suspicion for a leptomeningeal involvement of a neoplastic origin. So here we have some images, and in the left we have an axial T1 spear, where we can see an incrustate optic nerve here with perineuritis, and you can also see it in the right mesh at the axial T1. We also have here an axial flare 2D, where you can see the extra-axial lesions, the first one in the left in the temporal lobe, and the right mesh and the fossa. Ancillary test took also on January 16. We had the infections, autoimmunity, inflammatory, and metabolic, all negatives. And we have just the IgG4 elevated. It's just like 3054. The CSF, the first CSF collected had an appearance of a turbate with low glucose, hyperproteinuremia with 302, and there was neoplastic cells was negative for the cytology at the first moment. Think more about granulomatous disease, or also inflammatory, or it could be still an infection disease. We also took chest CT and abdominal CT, besides the patient have no alterations in the examination, in the physical examination for chest and abdominal. But we found a cystic lesion with thick and regular margins at the right lower lobe of the pulmon. We also find adjacent solid nodule with well-defined margins is spiculate solid nodule of the posterior segment of the right upper lobe. And there was also mediastinal lymphadenopathy. The radiology report was found suggestive of a primary neoplastic process with nodal dissemination. For the abdominal CT, we had a hepatic nodular lesion that was compatible with an hemangioma. And we also found a sclerotic nodular lesion, posterior superior portion of the L4 vertebral body, that was at the moment indeterminate. So here we can see the cystic lesion on the right lower lobe with an adjacent solid nodule. For further investigation, we ask for a new CSF. And the new CSF now has come to a cytology positive for neoplastic cells. And we had the right lung biopsy, and the right lung biopsy was with a typical epithelial proliferation that was really suggestive of adenocarcinoma with a lipidic growth pattern. The immunohistochemistry has a TTF1 positive and a Nipsin A positive that was compatible with a pulmonary alveolar origin. We see now the new CSF cytology was malignant for metastasis, and the conclusion was a metastatic adenocarcinoma. For the follow-up of these patients, the oncology team was doing intrathecal chemotherapy with methotrexate, but with palliative intent, and there was also integrative palliative care for the patient. And finally, for discussions about the leptomeningeal carcinomatosis, I bring here some key facts that 5% of the patients with systemic cancer like breast, lung, and melanoma are the principals can have the leptomeningeal carcinomatosis. And ocular involvement may be the first manifestation of this patient. Other finds we can see is diplopia, ptosis, papilledema, anisocoria, and multiple cranial neuropathies. And I bring here some neuro-ophthalmologic red flags for these suspicions. And we can see the progressive bilateral involvement with perineuritis, associated with retinal hemorrhages, peripapillary yellowish lesions, NRI showing meningeal thickening, abnormal CSF biochemical profile, and poor or absence of a response to corticosteroid therapy. It's our patients just have just all of these finds. So finally, for take-home messages, you can see that not every painful optic is demyelinating, and initial CSF cytology may be false negative, and repeating the examination is essential. Systemic malignancy should be considered even the patient or the family has no prior cancer history, and a typical optic neuropathy should always prompt investigation for systemic or infiltrative diseases. This is the reference I used to doing this presentation, and thank you for all.
Thank you, Rodrigo. Great. And that's some take-home messages here. The first one, not every visual loss that we have painful eye movements are optic neuritis. That's important. We have a progressive pattern here, starting in November, after December, at the subsequent eye. So we have progression here. We have to think about infiltrative cause. Yes, we always have to rule out NMO, MOGAD here, like CRM5, but in this case, we have a sign in the MRI, we have like a flattening of the posterior pole there, inversion of papilla, like papilledema. Yeah. This one. Not only that, like that, we have the inversion, we have a large edema here. It's not typical in optic neuritis. We have so huge edemas like that. So we have to think about it. Obvious, the leptomeningeal infiltration, the lesions of the dura, we have to think about that. And the other point, the CSF, not every lumbar puncture have positive cells in the first one. We have to repeat. It's a main sign here. And the first sign of this patient, we have a case of emergency room, was the eye. Sometimes we can't save it, sometimes it's the palliative, but we have to do the diagnosis. That's the main message here, the take-home message here. in the no-smoker patient, relatively young. So the eye was the first moment here. That's the take-home message, I think. Thank you. Dr. Luciana.
Well, can you show the fundus?
The fundus.
When you see such a huge edema, the first thing I think about is something
Compressive. Yeah.
Even infiltrative or meningitis or any kind of compression in the organ. Hello? Okay.
I think it's not working.
So when I see such a huge edema, I have to think about compression, even direct compression for a tumor, for example, or infiltrative pattern or perineuritis. And perineuritis is very light to the pain in the movement.
Yeah.
And it begins before the beginning of the visual loss. Is a very suggestive case. So when we go to the diagnostic image, you can see the image. We see that there's a perineuritis, but we see that multifocal.
Yeah.
So it's something we have to think, and then we have all these images. But when you go to the diagnostic hypothesis, these diagnostic hypotheses are lied to any enhancement of the meninge that involves the optic nerve. So we have to think about inflammatory diseases, infectious diseases, or tumors and other infiltrative diseases. It's a very beautiful case that shows how important it is to think step by step to make a diagnostic hypothesis, because if you were going to think about to trust only on the exams, for example, the CSF, there were no cells, but we know they can be false negative. But we repeated the exam because we were so sure of the diagnostic.
Yeah, like the DG4, it's a mimicker. Yeah, it's not specific. Yeah, here. Yeah.
It's not working, the phone.
Hello? I think mine is working. All right. Dr. Kozar, Dr. De Silva, wonderful case, very difficult and extensive workup, of course. Can you go back to the picture of the optic nerve, the MRI?
And the MRI,
that showed the MRI of the,
Yeah.
So this perineuritis question, this comes up, and this is a mimicker, as you've pointed out. The other thing to think about with these are optic nerve sheath meningiomas that can also be very easily confused with sarcoid, IgG, and all of these other things. So the other thing I wanted to say about the IgG4, and I didn't see a coronal of the orbit.
Oh, no. Here we don't have it.
The one thing, the one thing I like to look for IgG4 disease is the infraorbital canal, which is often enlarged with IgG4 disease. So that's just another helpful radiologic sign. You had so many other things that were arguing against this inflammatory condition that you clearly went down the right road. But those are just a couple of things that I think of in the differential and other ways to sort of look for that as well. But one wonderful case. Thank you for presenting.
Thank you. Thank you.
I would like to invite Nina Lusky. She's visiting from UIC. And the advisor is Dr. McIntosh. Gente, ajuda ela. Acho que deu.
Okay. This doesn't work though with my computer. Oh, perfect. Ah, perfect. Thank you. Fake. Perfect. Thank you. Okay. Can everybody hear me okay? Ok. Oi, boa noite. Meu nome é Nina. Eu sou residente em oftalmologia em Chicago, aqui em intercâmbio. Eu sou meia brasileira, mas eu não falo bem português. So the rest of this presentation will be in English. That one was for you, Sinji. So my name is Nina Lusky. I am presenting this case. Thank you, Dr. McIntosh, for the advisement. All right. So I have no financial disclosures. This is a case of a 34-year-old male with no past medical history, presenting with 1 week of decreasing vision in both eyes and severe headache. He was referred to UIC for this concern of papilledema. He says that he started to lose vision in the right eye about a week ago. It started out in the top corner, and then slowly over 2 days, he woke up with no vision in that eye. The left eye was then subsequently involved as well. He endorses a headache and then pain with extraocular movements, but denies any pulsatile tinnitus, transient visual obscurations, and then there's no hormone use, doxycycline or other tetracycline antibiotics, vitamin A, steroid use, or recent trauma. He has no past ocular history and is not on any medications. His past medical history, he has some reflux, but otherwise is a healthy guy, just taking famotidine and then started on naproxen for the headache a few days ago. Family history is negative for autoimmune diseases, and he had an unremarkable social history. On exam, visual acuity was light perception in both eyes. Intraocular pressure was normal. He had these dilated, minimally reactive pupils, which made assessing for an APD very challenging. And EOMs were full, but he endorsed that pain. Color, he wasn't able to see the test plate. On exam, it was notable for some scleral show, inferiorly and superiorly, and then disc edema with mild vessel obscuration in both eyes without vitreous hemorrhages. Otherwise, his exam was normal. So at this time, I want to pause and open up to the residents. What would be on your differential? Rodrigo started us off nicely there too, so thank you for doing the heavy lifting. Anybody with some things for a differential for a bilateral disc edema? Thank you, UIC residents. Unifesp, anybody? It's okay if no is the answer. Okay. Well, for sake of time, so we can think of vascular causes. GCA, probably not in this guy who's 30-something. Bilateral NAION didn't have any other risk factors. Hypertension papillitis, still on the differential. And then bilateral CRVO, rare, but could be. Infectious causes, syphilis, TB, Lyme disease, Bartonella. You can think of inflammatory causes, optic neuritis, typical and atypical, sarcoidosis, radiation, induced optic neuropathy. Then we can think of infiltrative diseases like leukemia or metastatic tumors. Compressive, I mean, this guy had, you saw his picture, a lot of scleral show. We could think of a thyroid eye disease with a compressive optic neuropathy or a mass. And then we've got to think of increased intracranial pressure, either primary or idiopathic, or secondary to medications, intracranial tumor, dural venous sinus thrombosis, and then, of course, intracranial inflammation, like meningitis and encephalitis can do this. Lastly, could be fake, pseudopapilledema with optic disc drusen. At this time, we obtained a workup, including imaging, which showed an abnormal signal and enhancement of the intraorbital portion of the left optic nerve, long segment abnormal signal and enhancement of the intraorbital and intracranial portions of the right optic nerve, and then abnormal prechiasmal enhancement as well. There was no dural venous sinus thrombosis or intracranial mass. And then MRI brain, C-spine, T-spine did not have any other enhancing lesions. So we'll walk through some coronal shots of his MRI here, which demonstrates the bilateral optic nerve enhancement. You can see it particularly well there. So, yeah, let's go back. There we go.
Now it's on? Okay. My favorite way to look at the optic nerve is through coronal sections, just because you get multiple slices through it. And always compare the nerve to the brain parenchyma. The nerve should be the same color, the same intensity. And so, Nina pointed some brain up there for us. So that's the color that the nerve should be. Whereas down below where the two nerves are, there's a couple of things you see. One, it's brighter, it's wider, but it's also thicker if you look at it. The nerve is thickened, and we'll get to that as well. So those are the two things. One is color, and two is how big the nerve looks. So it's thickened as well.
Thank you, Dr. McIntosh. Going on with his workup, vitals, he had no fever, pointing away from encephalitis, meningitis. His blood pressure was mildly elevated, 144 systolics. He had a lab workup, which was largely normal: CBC, CMP, syphilis, West Nile virus, Sjogren's, ACE lysozyme, aquaporin 4, thyroid studies, and a chest x-ray, all normal. But his MOG serum antibody was elevated with a titer of 1 to 640, so definitely positive. So at this time, he was, the one thing, sorry guys, my lumbar puncture slide dropped out of that too. I'm not sure, but that's okay. He also had a lumbar puncture, which showed an opening pressure of 36 centimeters of water, or H2O, and then it was otherwise normal. So normal protein, glucose, cell count with differential, infectious workup with HSV, CMV, VZV, and yes. So sorry about that, but opening pressure was elevated. That's the key takeaway. So at this time, we've got kind of two things we're dealing with. We've got myelin oligodendrocyte glycoprotein antibody disease, or MOGAD, and then we've got this intracranial hypertension. The question now becomes, does he have two things going on? Is there a kind of a primary idiopathic overlying intracranial hypertension, or is it secondary to this neuroinflammatory process? We didn't know at this point. So he was admitted for treatment. He received 5 days of high-dose IV methylprednisolone, followed by a PO prednisone taper. He got 5 days of plasma exchange therapy as well. And then he was also treated with oral acetazolamide, 1,000 milligrams BID, given the elevated ICP. So let's review his clinical course. He initially presented in February on the 21st with light perception visual in both eyes on no treatment. He was admitted, the opening pressure was elevated. He was started on Diamox at that point, and then his vision dropped a little bit more. He had not started treatment yet with the IV methylprednisolone. It was LP and NLP in the left eye. After a 10-day admission, he got IV methylpred, the Plex therapy, as well as 2 doses of IVIG in preparation for maintenance outpatient treatment, given the kind of extent and aggressiveness of the vision loss in both eyes. And then he was also treated with the Diamox and discharged on that with the PO pred taper. His first visit at UIC now about 2 weeks after discharge on the 13th. He's on the PO prednisone taper at 10 milligrams now, and Diamox 1,000 BID. Vision has dramatically improved to 20/30 in the right eye and 20/25, and color is now full. At this time, there was this question that remained: are we treating idiopathic intracranial hypertension, or now that the disease is under control, are we okay to kind of take him off the Diamox and monitor how he does? If the edema returns, he also had his review of systems was negative for any of kind of the red flag things we think about with idiopathic intracranial hypertension. So the decision was made to taper him off of that. We also got baseline OCT-RNFL and Humphrey visual field. In the right eye, we see some mild temporal swelling, atrophy, but otherwise was full. The left eye was full. And his Humphrey visual field shows these dense inferior arcuate defects in both eyes with these scattered superior defects. So vision's improved significantly, but there's still a great impact on his vision. Now, about 6 weeks after his hospital admission, he's been transitioned to maintenance therapy with 1 gram per kilogram of IVIG. His vision continues to improve at 20/30 and 20/20 in the left eye, and color remains full. We got an updated visual field, and we continue to see resolution of these defects. The superior visual field looks much improved in both eyes. We're still left with some inferior defects, but largely looks much better. And then we last saw him back in October of 2024. He then has just been following with our neuroimmunologists. He's still on maintenance therapy. He never had another recurrence. And his vision, when we last saw him, was 2025 and 2020. So a pretty remarkable recovery from light perception and no light perception vision. And then we do see that there are pretty significant atrophic effects on both optic nerves with some residual visual field defects in both eyes, right greater than left. So objectives for tonight. First, I want to review a little bit about MOGAD. Second, we'll talk about, can MOGAD be associated with intracranial hypertension? SAR is the first case. Are there other cases that go along with this? And then we'll talk a little bit about acute and maintenance treatment. So myelin oligodendrocyte glycoprotein's primary function is not well understood. It acts as an adhesion molecule on the surface of oligodendrocytes and gives structural integrity. And it only makes up about 0.05% of myelin, but is found in many other animals. So there's thought to be some biologic importance that we just don't fully understand yet. So MOG optic neuritis is characterized by an autoimmune attack on the surface of the myelin sheath by MOG-specific antibodies. The pathophysiology is not completely understood, but it's probably due to some molecular mimicry, as a lot present with kind of this viral prodrome, or maybe just this imperfect tolerance to the thymus, so the plasma cells develop these antibodies to the MOG-specific antigens. These MOG-specific IgG antibodies are then thought to activate the complement system, as well as mediate antibody-dependent cellular cytotoxicity, ultimately leading to optic nerve inflammation and damage. A little on the epidemiology. It used to be part of kind of this multiple sclerosis bundle, but it's now recognized as its own entity. The prevalence is estimated to be about 1.3 to 2.5 cases per 100,000 people, and the annual incidence is 3.4 to 4.8 cases per million patients. There's no racial or gender predilection, and it typically presents in the 3rd decade of life. But it's really important to keep this in mind when we see children who are presenting with optic neuritis, as 30% of cases are diagnosed in children. And then, as I mentioned, often preceded by this kind of viral or infectious prodrome. One thing to note too, in kids, we'll often see optic neuritis as part of their clinical picture, but ADEM or is kind of more acute disseminated encephalomyelitis is more common in this group. Symptoms are typically include vision loss. It's often bilateral and quite extensive. Pain with eye movements as other optic neurities. I don't know if that's the plural. Headache, seizures, and then weakness, numbness, pain loss of bladder or bowel control, like in other demyelinating diseases. Some signs more common in MOGAD include optic neuritis, often like a long segment optic neuritis. Optic disc edema is common. It typically affects more of the anterior nerve segment. So unlike in MS, where 60%, we won't see that. It's higher in the MOGAD group. Transverse myelitis, brainstem demyelination, cerebral cortical encephalitis, and then ADEM, as mentioned, more common in kids. 40 to 50% of cases are monophasic, so they shouldn't happen again. And the disease is very steroid responsive. So patients often have complete or almost complete recovery after treatment with steroids. However, 25% of patients will have some residual vision loss, as is the case with our patient, though overall much better from his starting point. Another difference is that actually on MRI, you'll actually see the resolution of the MRI lesions in MOGAD, unlike in MS and NMO. And then the prognosis tends to be better than these other two diseases too. So the diagnostic criteria for MOGAD was not well established, but in 2023, a panel of international experts met and proposed a consensus diagnostic criteria for MOGAD. They reviewed 378 papers and published between 2010 and 2021. And here's a little summary of what they found. So to diagnose MOGAD, the paper kind of lays out this three-step approach. First, does the clinical picture give a demyelinating event, okay? Is there optic neuritis, transverse myelitis, ADEM, for example? Next, once we've established that clinically they look like there's a demyelinating disease, we get the serum testing for MOG IgG antibody. If the test is positive, they define that as a titer greater than 1 to 100. Then we've got our diagnosis. The clinical picture meets MOGAD. The titers are suggestive of that. However, if a few things, one, the titer is lower than 1 to 100, CSF is positive for the antibody, but not the serum, or there's one other. I'll come back to that if I remember it. But then you must have kind of meet some other criteria. You must have supporting MRI or clinical features that are suggestive of MOGAD, and it's important to exclude, another etiology of this, such as MS. So one other thing that I found interesting from this panel's recommendations, and maybe Dr. McIntosh can speak to this more, but we don't typically practice like this. We generally see optic neuritis, and we test everybody for the MOG antibodies. But their recommendation is actually that patient selection should be a little bit more focused to improve the positive predictive value of the testing. So they recommend performing the test only in those who have clinical and radiologic findings concerning for MOGAD, rather than in all patients with a demyelinating disease. The caveat, if a kiddo comes in and they have signs of demyelinating disease, they should be tested because the rate of MOGAD-associated demyelinating disease in this group is much higher. So it represents 50% of cases of optic neuritis in kids versus 5% in adults. And then lastly, if someone has findings consistent with MS, lesions disseminated in space and time, we don't need to test for MOGAD in this group as there's a risk for a false positive, kind of muddying the diagnosis. red flags when doing this test, if something's at the assay, right at the assay cutoff, if they don't have improvement after steroids, the kind of timeline of the disease, if MRI findings meet MS criteria, if they still have these enhancing lesions on MRI over 6 months later, as we know they often go away. And then if there's this positive CSF MOG antibody, but not in the serum. I'll move through this a little quicker. I know I'm short on time. Thanks, guys. But let's talk about these MOGAD-associated intracranial hypertension. Are there other cases? In our patient, he came in, he had bilateral disc edema, exam ended up being positive for the MOGAD optic neuritis, bilateral optic neuritis, but then there was this confounder of high opening pressure. It was unclear if it was due to intracranial, like a secondary disease process, idiopathic intracranial hypertension, in addition to the optic neuritis, or if it was secondary to the inflammation, the acute inflammation. We decided that, after observing him without return of optic disc edema, no red flag symptoms for IIH, that it was most likely due to the acute neuroinflammatory process. So there are other cases that have been reported. For example, so Wendell et al. Looked at this case of 8 children that were diagnosed with MOGAD optic neuritis, and they were actually misdiagnosed with fulminant IIH initially. They presented with vision loss and rapid vision loss and headache, just like in our patient, just like patients with fulminant idiopathic intracranial hypertension. They were treated with acetazolamide and more invasive procedures, as well as IV methylprednisolone after the diagnosis was made, the proper diagnosis was made, and they achieved great visual function. The authors propose that, measuring opening pressure in neuroinflammatory diseases might be helpful to identify cases that need some additional management with ICP. And then we've got this multi-center retrospective review of 84 cases of MOGAD. 28 of them had documenting opening pressures, as we often don't even ask for that in our demyelinating cases. But of these 28 that had reported opening pressure, 6 of them, or 21%, had elevated ICP documented to be between 26 and 45. So once again, they find this association. And all 6 of these cases presented with bilateral optic neuritis. So yes, we do see this in other settings. We don't always obtain an opening pressure, so we might be under-detecting this as well. Lastly, a quick comment on treatment. No randomized control trials, but typically our patients are treated with 1 gram IV methylpred for 5 days plus a PO steroid taper. On discharge, you can consider IVIG as well. And then there's more push to start Plex earlier in patients with suspected NMO or MOG. It's recommended to do 5 to 7 sessions every other day. And it has been associated with better visual outcomes, but once again, there are no randomized control trials, so could explore that. Maintenance treatment, typically not started after the first episode, 50% monophasic, so they don't happen again. But you'll remember that our patient was started on IVIG immediately on discharge. That was because the magnitude of his vision loss was severe, so that it was determined that, let's decrease the risk of even having another episode. So it is the best treatment of choice for maintenance treatment is monthly IVIG infusions. It's been found to have the lowest relapse rate compared to other immunosuppressants, but might be cost prohibitive. So some alternatives you can think of, a good second option would be oral azathioprine, or oral mycophenolate mofetil is good, but has been associated with a higher rate of recurrence compared to azathioprine. So, key points: not every bilateral disc edema with headache is idiopathic intracranial hypertension, even with an elevated opening pressure. and consider performing we can consider performing opening pressure in cases of suspected MOGAD or demyelinating diseases to help guide kind of supportive treatment. Obrigada.
Thank you, Dr. Lusky. That was a great presentation. Again, just all of the things that we think of when we see disc edema. It's easy to jump at IIH, but this is an atypical patient. We know that really only 5, maybe 10% of patients are male who have IIH, so we really needed to think about that. This underscores the importance of neuroimaging to help us with this diagnosis as well. And I did want to just call out in neuro-ophthalmology, and I'll mention it in my talk as well, we don't have as many clinical trials as, for example, the retina community does. But a new clinical trial that's coming out is called Timely Plex. It's actually not looking at MOGAD, but at NMO to understand exactly what Dr. Lusky mentioned about when and who should get plasma exchange, because we really don't know. So this is a study that hopefully will help us answer that question. And in my talk, I'll talk a little bit about some of the other clinical trials that are important in neuro-ophthalmology, but I did just want to mention the Timely Plex study, which is going to be an important one for our community. Any thoughts or questions from the audience?
Basic question here. How long this treatment has to continue?
Like IVIG?
We don't know.
Yeah.
So right now it's indefinitely. You could argue that maybe we could stop it for him. He's only had one. And then if he has a second, then that would mean we would have to do it forever and indefinitely. But we don't know the answer to that question.
It was very aggressive, right?
Yeah.
So let me see if Dr. Monteiro is online. If he can. Do we have online? Yeah. Dr. Mario Monteiro, would you like to make a comment? He's a full professor at University of São Paulo. He was listening. So I don't know.
I'll get set up while you're waiting on questions.
Not yet. Because
Because
Ana Luisa is going to present me and then...
Nós temos assistindo também a equipe da neurologia aqui da Escola Paulista de Medicina. Se eles quiserem fazer algum comentário, alguma pergunta, o serviço de desmelinizante é muito forte aqui na escola.
Why did they have scleral show?
Yeah, I thought about that. I didn't take that picture, but I think that was done after dilating drops were put in, so maybe that has something to do with it. But the thyroid workup was negative, and there was no extraocular muscle or enlargement or tumor in the orbit. But that's the only picture we have, I think. That's the only picture. Okay. Oh, there was no dilating drops. Okay. Let's look at him again then. We haven't seen him in a year and a half or so. Yeah.
So we have the 4 full professors of our department are here, right?
Yes.
Professor Ana Luisa Hofling Lima, Professor Michel Fará, Professor Adriana, and Professor Solange Salomão. So Professor Ana will introduce the conference, what it means to us here.
Yes, this is an important conference for us. We have every year in the first trimester of the year, the conference Renato de Toledo. And for you, just to know, this conference started in 1981. So we have several presenters, but never someone from abroad. So in 2026, we're going to have, for the first time, you coming from Chicago. And this is also happening because of the situation that we have having in Chicago and our department working together with residents and fellows. And for you to understand also the importance of Renato de Toledo for our history, Professor Renato Toledo was graduating at the medical school at the University of São Paulo. That's the other university that we have in São Paulo in 1937. Then he came to Escola Paulista de Medicina 1 year after his graduation. And here he did his post-graduation course, and also he was chief of our department. At that time was not called department, it was discipline. And then he continued here as a professor, and then he became the head professor in 1967. Professor Renato de Toledo was also working very close to the Pan-American Association. So we have him with the internationalization of our department and working with the other universities in Brazil. Also, he worked at the Brazilian Council of Ophthalmology in several positions, helping the growing situation of the ophthalmology in Brazil. He also helped us to have all the values that we have until today of having teaching, research, and patient care. So it's our pleasure to have you here, Peter, as you are also very close friends of Wallace and Norma, working together with the medical school in Chicago. We're going to have you presenting the 2026 Renato de Toledo conference. Norma will introduce you, and it's going to be our pleasure to have you here. Thank you. You want me to leave this? No? Can I leave this? Okay. Deixa aqui. Hã? Eu vou ler, daí a gente troca. Tá bom, então fique à vontade.
So, Professor McIntosh is an international reference in neuro-ophthalmology. He is associate professor and director of neuro-ophthalmology and medical residency program at UIC, Chicago, director of the Global Ophthalmology Fellowship, and I have some slides about this because it's very interesting for us to know what this Global Ophthalmology Fellowship is, recognized by leadership and contribution to global ophthalmology, has active participation in international programs in education and training, and is our partner here in exchange residents between Unifesp, UIC, and I know many other institutions. Let me change.
Não? Você vai sem? Você tem que ir.
So Professor Peter William McIntosh, he gave me those slides so I could present. This is about global ophthalmology at University of Illinois at Chicago. Okay, it's also called Illinois Eye and Ear Infirmary. So he mentioned at the presentation he had at the UIC alumni last November that UIC has these resident exchange programs, and we are here but also with KU University and others if interested. Faculty with global programs, and we have Brazil here. And the goal is to have significant additional global academic presence. Some photos he shared with us here from Brazil, some from Japan at Keio University. And the purpose of this global ophthalmology residency track is a 4-year curricula to provide an opportunity to individualize training, to access to special faculty, access to special materials and resources, specialty research projects, support to attend and present at specialty meetings, and field experience with one of our global partner institutions in Honduras. So here is the resident track in Honduras. How often do you visit them? Once a year. So they have field activities there. This is the chair of the department, Dr. Paul Chen. This vice chair is Dr. Pete Setabatur. Professor Peter McIntosh is the associate professor, and we said director of NEUROF. And this is the faculty, local faculty of Haiti, right? Hospital University of Haiti. Some adjunct faculty, of course, we never do everything alone. And here there are rotation sites of this fellow in global ophthalmology. So Haiti, Thailand, India, Saudi Arabia, Costa Rica, São Paulo, Brazil, Kenya, and Honduras. So it's very interesting. This is Honduras, where they were, where you go, right, once a year. And there, the facilities there, operating room, lodging, some parties, and also some trekking activities, and mainly ophthalmology teaching and patient care. So in Kenya, this is the site they have, Kizia Eye Hospital. Okay, and some pictures from there. And this is important, the best fellows. Timothy Todd is now a faculty at University of Missouri. Emily Cole is a vitreoretinal fellowship at University of Michigan and retinal faculty of University of Colorado. And 23, Catherine is in private practice. But you must have more, right? 25. Not finished yet. New one starting. So this is a very interesting program. So Professor McIntosh, it's an honor to have you here in person to deliver this Renato de Toledo lecture. He has been our partner. He facilitates the way of Unifesp residents to visit UIC, and together we coordinate the visits by UIC residents to our institution. It's with great gratitude that I invite Professor McIntosh to the 44th Renato de Toledo lecture. Thank you very much for being here.
Thank you. Obrigada. Thank you very much for the warm welcome. Oh, I don't need to. Okay. Okay. Thank you very much. It's Can you hear me better? Yeah, okay. It's a pleasure to be here. Just a quick word about the global ophthalmology. Global ophthalmology is a big part of what we do at UIC, and we're grateful for our partners here at Unifesp that allow us to do this and include our residents. I have 3 of them there. Greg, Courtney and Nina. They're here for a week. Every year we send 3 residents here and 3 to KO. I understand for the first time this year, you're also sending residents to KO in Japan. So that's an important relationship triangle that we have. Some of that has to do with Dimitri Azar, who was instrumental in setting some of these exchanges up many, many years ago. We're grateful to all of the leaders that were part of this. A lot of what we do in global health is about capacity building and teaching and learning from each other, so we're always grateful to be able to do that. Of course, it's my honor to be giving the Renato de Toledo lecture today. I was reading a little bit about him before I came here, and also hearing the wonderful synopsis. Thank you. It's quite an honor, and also to be the first non-Brazilian. Oh my gosh, yeah. It's very, very big shoes to fill, so I hope that you enjoy what I have to say, and maybe we can talk about some of what I'm going to say. But it's an honor to give this lecture today. Thank you very much for the invitation. So what I'm going to talk about is IIH, which is why I chose that. One of the reasons I chose the case that Nina presented, this sort of complex picture of is it or isn't it. And I have no financial disclosures. So just as a background, you know, IIH in the name is this term idiopathic. So by definition, there is no tumor, there's no inflammation, or anything else that's causing it. These patients have papilledema, elevated intracranial pressure, but the most important part is this last statement, that the visual function is the most important morbidity. Sure, these patients can have terrible headaches, they might have double vision, these other things. All of that can resolve and we can treat. If we don't treat this to prevent vision loss, the vision loss can be permanent. And that is the real reason that we as ophthalmologists have to be involved in the care of these patients. We hinted at this earlier. The vast majority of these patients are female, but in childbearing ages, so this sort of around the age of 30. In the idiopathic intracranial hypertension treatment trial, I'm going to mention it several times. That's one of the few important studies in neuro-ophthalmology. You should know this study if you're going to talk about anything in neuro-ophthalmology. 97% of those patients were female. These patients are obese or have recent weight gain, probably no racial influence, and especially in men, there's a increased risk in patients who have sleep apnea. Some important drugs that we ask about that can incite this and cause secondary elevated intracranial pressure are tetracyclines, synthetic growth hormones, vitamin A, and then some of these medical conditions like Addison's, anemia, lupus, and then the withdrawal from chronic steroid use. We don't fully understand what is causing this condition. There are a few thoughts around this: decreased CSF absorption from the arachnoid villi. Those are in the ventricles whose job it is to absorb this fluid, but for some reason they're not working the way they should, and that's been seen in radioisotope cisternography studies. Possibly compression of those arachnoid villi from the elevated intracranial pressure, kind of this chicken and the egg story, which one causes which. And then a very important secondary cause is venous sinus thrombosis or stenosis, or elevated intra-abdominal pressure from obesity. We think that there must be some endocrine bias given that it's such a female predilection, and that there's this endocrine bias in patients with Addison's, or as I mentioned, the withdrawal of steroids. The IIHT taught us about what some of the important presenting symptoms of this condition are. By far and away, headache is the number one. This headache is different from migraine in that these patients often feel worse lying down, feel better when they're up. Importantly, though, this headache can usually be managed in many ways other than just CSF pressure reduction. So we'll talk a hint about that a little bit later. Transient visual obscurations are when the patients move position, the vision blacks out for a second or two. These patients can also get back pain through a radiculopathy. The high pressure can push on the nerve roots in the spine and cause back pain. Pulsatile tinnitus, double vision, and then of course vision loss. A quick word about how these patients get double vision. It's a very specific type of double vision that's a horizontal one related to 6 nerve palsies. This can be as the pressures in the brain change, you can get tethering of the 6th nerve. And so in this little diagram, you can see the 6th nerve comes out from the anterior part of the brainstem, turns 90 degrees, goes cephalad, and then turns another 90 degrees to enter through Dorello's canal into the cavernous sinus. And as the brainstem and the brain change positions relative to this pressure changes, it can cause stretching of the 6th nerve and can cause dysfunction. So whenever you see a patient with a 6th nerve palsy, you should always think of elevated intracranial pressure. So look for disc edema, just as a corollary to this condition. You can also get a couple of other brainstem dysfunctions related to 3rd and 4th nerve palsies, and INO, skew deviation, even nystagmus. These are very rare, but these are possible. We mentioned neck stiffness, lower back pain, and extremity weakness. So from the IIHT, we know that patients with IIH are solidly obese. In that study, they had an average BMI of 39. So always think of this in your patients who are obese with headache and changes in visual acuity. The modified Dandy criteria are what give us the definition of IIH. It's papilledema, normal neurologic exam, normal neuroimaging, normal CSF, but elevated intracranial pressure. So that's really the only abnormality that you should have. In adults, the pressure is considered abnormal if it's greater than 25 centimeters or 250 millimeters of water. In children, the cutoff is 280. And the reason for that is that often these pediatric patients need anesthesia to be able to tolerate the procedure, and that elevates the CSF pressure as well. But you can also make a diagnosis of IIH without papilledema. In order to do that, you're going to have all of the above, B through E. And if in addition to that, there's an abducens nerve palsy, you've made the diagnosis. These patients really mostly need headache management. Without papilledema, you cannot lose vision. And there have been a couple of studies that even show that if you have this diagnosis without papilledema, it's unlikely that you will further on develop papilledema for some reason that's not fully understood. You can also suggest the diagnosis if you have the above without a 6th nerve palsy, but with some of these radiologic findings. So an empty cella, flattening of the posterior globe, distension of the perioptic nerve sheath, and transverse venous sinus stenosis. So the modified Dandy criteria. A quick word about the Frisson score. So I like to use this to define what the nerve is looking like, because it's an easy way for us to even show Frisson grade 1, changes to 2 or 3, and then maybe improves back to 0. With Frisson grade 0, we have a completely normal nerve with no elevation. So this is normal. With grade 1, we start to see the early signs of disc edema, and we see this C-shaped swelling. You can see there's swelling sort of about 270 degrees, but the temporal side of the nerve is flat. So this is low grade. And even this with grade 2, which is 360 degrees of disc edema, is still considered low-grade disc edema. And it's not until we reach grade 3 where we start to see vessel obscurations, which means the blood vessels, as they cross over the optic nerve head, become blurred because they're hidden under the swollen optic nerve tissue. Grade 4 is a little bit more, and grade 5 is complete vessel obscurations. The Frisson score doesn't tell us anything about hemorrhages or cotton wool spots. Those are things we have to comment on separately. So you can get peripapillary hemorrhages. We saw that in the first case today. Retinal or choroidal folds can look like this. So just like you can get fluid from the nerve that happens in neuroretinitis, you can get fluid from the nerve from elevated intracranial pressure, like this in a choroidal fold, and you can imagine that might affect the visual acuity as well. And another presentation are these patent lines, which are circumferential fluid under the retina, circumferential to the optic nerve. Before we go on, I want to talk a little bit about some mimickers of disc edema. And so the optic disc drusen are an important one to keep in mind. These are calcium phosphate deposits in the optic nerve head that can cause the nerve to look elevated. They're not hyperemic, so if you did a fluorescein angiogram, there would be no leakage. Can be associated with angioid streaks or retinitis pigmentosa. In kids, they tend to be buried and they move forward as they get older. So that's why it may be, if this is a child who's had many eye exams, this may be what may look like an acquired nerve anomaly, but really that's because drusen migrate as we get older. So a quick and easy way to look for that is with a B scan, where you can see a hyperechoic lesion at the optic nerve head. Another quick way to do it is with a fundus autofluorescence. And you'll see autofluorescence like this. You can even see it on a CT scan because it's calcium. The most sensitive technique, though, is the OCT. With enhanced depth imaging, you can see a number of deep buried drusen, as well as the posterior extent. It delineates the extent of the drusen, but it also gives you information about the retinal nerve fiber layer to tell you about the health of the optic nerve. We can also use B-scan, as you can see here, to measure the optic nerve sheath diameter. And that's another way to sort of track how patients are doing. You can also measure that on MRI and on the pituitary-sella ratio. So in this study, they looked at the thickness of the optic nerve sheath in patients with pseudopapilledema, so basically a normal optic nerve versus papilledema. And on the ultrasound, you can see a significant difference, 5.2 versus 4.4 millimeters. In the MRI, it's even more dramatic, 7.2 versus 5.2 millimeters. And the pituitary-sella ratio, 0.7 versus 0.3. So these cannot define papilledema, but if we see these are interesting ways to sort of monitor and follow patients as they are being treated. So here is a sagittal MRI, T1 without contrast, showing the optic chiasm above an empty cella. So an empty cella is one of those signs that you're allowed to have in elevated intracranial pressure. This is a T2 axial MRI, showing dilation of the optic nerve sheath, as well as flattening of the posterior sclera, right? So these are, again, some of those soft signs you're allowed to have. Here on the MRV, we're evaluating for venous sinus thrombosis or stenosis in the superior sagittal, transverse, or sigmoid sinuses. And the most common location for stenosis is between the transverse and the sigmoid sinus. So that's what I ask my radiologists to look for. The vision loss in IIH is insidious and often spares the central vision, especially early in the disease. The most important test, if you can only order one, would be to do a visual field, because you'll see visual field changes before visual acuity changes. So here in the IIH-TT, I like this graph. This is showing that hill of vision, and what you'll see is patients with normal, and the dotted line is patients with mild, and this red line are patients with severe papilledema. And in all three cases, you can see that that hill of vision remains quite high. Their central vision remains good. It's the peripheral vision that goes first, underscoring the reason why in patients, if you're worried about elevated intracranial pressure, the visual field is the most important test you should order. Here's an actual patient of mine demonstrating again some of these findings. If we look, this is a Goldmann visual field. This is an old technology which we actually have just stopped doing because they don't support the machine anymore. But what this does show is on the left a normal visual field. You can see the visual acuity is normal, 20/20. This is a normal blind spot and a normal peripheral vision. If you're not familiar with the Goldmann, this is a kinetic tool where the technician will draw in from the periphery. So it's very good at mapping out the outside periphery of vision. It's not very good at detecting the central vision. But if you compare this left eye field to the right eye, you'll see three important findings that you will get with papilledema. This patient has relatively good visual acuity, 20/30. Remember, the visual acuity goes later in this disease. but one of the first findings is this enlarged blind spot. And that happens as the optic nerve gets swollen, the peripapillary retina gets elevated, and that becomes blurry for the patient. You can refract that out, but that's what causes the enlarged blind spot. Not too worried about that part. These other findings are more worrisome. One, this nasal step, kind of like you would see in glaucoma, is a sign of severe retinal nerve fiber damage, and the peripheral constriction of the nerve of the visual field is the second important sign. So blind spot enlargement, peripheral constriction, nasal step changes, those are some of the findings in the visual field with papilledema. And then a quick word about fulminant IIH, which is a severe form of IIH that is rapid in onset, that can have severe visual consequences. And these patients have a much higher mean opening pressure of over 50. These patients need aggressive treatment with maximal medical and then also surgical treatments. But if we go back to the standard IIH, these patients only had an opening pressure of about 34. The treatment, again, comes out of the IIH-TT, which is acetazolamide. That is the first-line treatment for this medication. It's a carbonic anhydrase inhibitor that blocks CSF production, and it's first line for mild to moderate vision loss. And this can be given up to 4 grams daily. But there's a number of side effects that I usually tell my patients about: paresthesias, dysgeusia. Importantly, this is category C in pregnancy. That being said, this has still been successfully used in many pregnant patients, even in the first trimester. Methazolamide is a similar drug with a slightly better tolerance, so sometimes I consider that in patients who don't tolerate acetazolamide. Furosemide is a second-line drug. It's a loop diuretic that's also category C. This can sometimes be combined with Diamox, but we have to watch for hypokalemia in particular. And then the third-line drug is topiramate. This is an anti-seizure medication. It has a number of other beneficial effects, such as it's a good headache drug. Many neurologists use it simply for headache. And it's also an appetite suppressant, so it can help with weight loss. Weight loss is a really critical part of this condition. The problem with weight loss is it doesn't happen fast enough. So these patients need CSF reduction medications or surgery acutely, but in the long term, the best solution is going to be weight loss. And in the IIH-TT, they talked about 5 to 10% body weight loss, diet, exercise. I used to talk a lot about bariatric surgery, but now weight loss, at least in the United States with these GLP-1 agonists, do you have access to those here? Yeah, that is, those have been a game changer for many patients. Steroids is a little bit controversial. Earlier, I talked about the withdrawal from chronic steroids can elevate intracranial pressure. That's because acutely steroids can actually reduce CSF pressure. And if you are chronically on steroids, the body resets that pressure, and that's what makes the withdrawal a problem. So we can't really use this for chronic use because steroids also have a lot of complications. But I will use this for these patients with fulminant IIH because a quick dose of steroid, we know that reduces ICP. And if we have a patient with fulminant disease, we're worried about blindness, we're waiting to get them to surgery, 1 or 2 doses of steroid is probably going to be helpful. Finally, the surgical options. There are 3 right now: optic nerve sheath fenestration, shunting, and venous sinus stenting. The problem is we don't really know when to do which of these. So here's an important study that about 5 years ago, a group was trying to answer exactly that. So patients were going to get medication and either no surgery, a fenestration, or a shunt. The problem was this study didn't recruit well. Patients didn't want a randomization tool deciding if they would get brain surgery or not, which is understandable, but unfortunately we then couldn't answer this question. And today we still don't know the best treatment. But many of us think for patients who have vision loss without headache, probably the fenestration is the best way to go. It's not brain surgery. You're not putting a device into their brain with all of the risks and complications that can come with shunting. So in my experience, for patients who've had mostly vision loss without headache, a fenestration has been a good solution. For patients who have headache, in addition to that, the thought is that probably the shunt is a little bit better. And we're now talking more and more about sinus stenting, especially if you can see that on imaging and your neurosurgeon can show a gradient across the stenosis. Okay. Many things. So, do you guys shunt or fenestrate here, or? Oh. Okay, so you guys do fenestrations, or have access, but not really. Okay.
It's good to show.
Yeah. So here is an example of a fenestration if you have not seen this. This is my colleague Nick Volpe. I used to do these surgeries, and I did it the same way. And what you will see is actually before we get there. So the approach to this, there's a couple of approaches. This one is using the medial peritomy approach, nasal peritomy. There's another approach through the superior eyelid crease. But this is what I was taught, and this is what I have been doing. So first, there's a nasal peritomy done here to access the medial rectus muscle. And then the medial rectus is disinserted from its insertion. And once that's done, it is reflected away. And this is actually a 30-minute surgery. It's very quick. Let me pause here again. So once the medial rectus is reflected, you can follow the globe all the way back to the optic nerve. And you can see it down here. This is the optic nerve. And then you take some kind of sharp instrument. And if you look carefully, you'll see a little gush of fluid. So that means he's entered that space and released the pressure from around the nerve. A fenestration is not just a little cut like that. There's more to it. It's a fenestration. Of course, that's a French word for window. And so you would create a 2x4 window. They're not going to show that part to reduce the risk of it sealing off or scarring closed too quickly. But once that fenestration has been made, you are finished. And you reinsert the medial rectus, you close up the peritomy, and you're done. This surgery can be done in 30 minutes versus a shunting surgery that can be many hours. So many of my neurosurgery colleagues will tell me, why don't you just fenestrate, because this is all that it takes. So here's a patient that I fenestrated many years ago, and you can see we talked a little bit about these sizes. Here, 6.2 centimeters. This is before surgery. 6.3 centimeters is the diameter. Here, after the fenestration, 5.3 and 6.0. So, and this scan was done just a week after surgery. So very rapid change in that perioptic nerve diameter. Interestingly, here on the imaging, you can even see the site of the fenestration where that little hole was cut in the optic nerve sheath. So, that's IIH. Beware of secondary causes. We talked about tumor and venous sinus thrombosis. There are some soft radiographic signs, the empty sella, the optic nerve sheath dilation. Remember that the visual field is the most important test for your patients with papilledema. You might see an enlarged blind spot, infranasal defect, or generalized constriction. You can get back pain and neck pain because of a radiculopathy. And fulminant IIH is the scary version of this that needs very aggressive treatment. Thank you, and I'm open to any questions or comments or discussion.
You have questions, Neuro? Yes, Leticia has. Microphone.
Now?
Yeah.
Peter, a great lecture. Thank you. Great. About the use of GLP-1 diagnosis of GLP? Do you use, I don't know, like that Ozempic, Mounjaro, about the use of that and HII? I don't know, it's a common theme. Yeah.
Yeah, there's not a lot of data about how to use it in these patients, but I will talk to them about it, especially if they tell me that they're struggling to lose weight loss. I used to talk a lot about bariatric surgery, and now I've shifted it to this discussion instead, and many patients have had great success. There are some studies coming out that I think might help to better address this. Right now, we don't have a clear answer. In my mind, whatever the weight loss mechanism is that works for the patient is the mechanism they should use, whatever they can do to lose weight. I then get this question about NAION from the GLP-1 agonist, and that's not really what our talk today is about, but just since you mention it, many of my patients then worry about having an eye stroke if they're on these drugs. And I usually tell them, you're probably more likely to have other complications from your weight and diabetes, and the risk of the NAION is much, much smaller than the risk of remaining obese and having uncontrolled sugars and those types of problems. So I would probably, if it were me, I would take the GLP-1 agonist. Mm-hmm.
So we'll have the input of Dr. Mario Monteiro. Can we see the image, Lucas? Hello.
Oh, hello. Well, congratulations on the important lecture. So I had just want to re-emphasize everything that you told. It's exactly what I think. One important thing that you mentioned, and I would like to draw attention, I still use a lot of the Goldman fields, and it's very good. I feel it adds a lot. Many times you have a better impression of what the field is like, because that's one point that I would like to mention. You mentioned it en passant, and I would reinforce that the importance of that. Maybe using the semi-automatic, the Octopus one. I also do this type of fenestration. That's exactly like you said. So congratulations on the lectures. Perfect. Okay.
Thank you. I appreciate your comment about the Goldman. I really find that a very useful tool. Particularly some patients can't cooperate very well or don't understand. You can coach them a little better. And if the visual acuity is particularly bad, those patients can sometimes do better. The problem, at least where we are, is they don't make the Goldman anymore. They don't support it if it breaks. And we lost the calibration tool, so we really shouldn't use it anymore, at least in Marin. So I don't know if you still have one and the calibration tool, and maybe I can borrow it.
Yeah, I still have. I still keep it, but we should start using the Octopus 900. She does exactly the same thing. It's hard for me because I'm old enough. I have a hard time with the computing. It's much easier with the manual stuff. But anyway, some people you have a feeling that they are very bad in the vision with the Humphrey, and on the other hand, they are not so bad as they look at the Humphrey. So you're not seeing the complete scenario without the Goldman. So I
agree.
I use it all the time. I mean, I use both. So, but otherwise, I agree. So I like to state the same thing. The important thing is to lose weight. So if they do lose weight, if we treat them early enough, we can hold the visual loss. Many of them. And when I start treating the patients, and many times I can avoid the surgery, because if you do treat them correctly, it's like glaucoma. I mean, it's similar. If you treat them well, you don't have to do as much surgery. But I agree with everything that you said. Perfect. Congratulations. Okay.
Thank you, Dr. Montero.
Thank you very much. Ivan, você quer entregar para ele? So we have just a certificate for you, and we have some photos to make